Greetings, I'm Philip Boone, and this is a quick medical genetics lecture about the disorders of fatty acid oxidation. This is part 2 in a 3-video series. In the first video, we went through the actual pathway by which fatty acids are oxidized in the body, resulting in energy precursors and also ketones through ketogenesis. I highly encourage you to go back and watch video 1 if you haven't previously. If you just want to refresh, you can either look at the last minute of the video in which I summarize everything, or you can just take a screenshot or open it in another window on your device and pause it so that you can go back and forth between the current lecture, which looks at the clinical features of the disease, and those biochemical pathways. So the clinical features of the disease, it turns out that this is a family of disorders in which all the disorders look fairly similar. So we'll talk in general terms, but point out one specific disorder, MCAD deficiency, and its features, as it's the most common disorder of fatty acid oxidation in the United States and in Europe. We'll go through the clinical features of this family of diseases, talk about them molecularly, what their inheritance and prevalence are, how you make the diagnosis, and this will be by lab tests. I'll go more into depth in the third lecture about all this, as this is actually the sole subject of that lecture, but we'll touch on it briefly here. We'll talk about the treatment and management of fatty acid oxidation disorders, what the differential diagnosis consists of, and mention some references as well. So let's dive into the clinical features. So most often these disorders present in infancy. In MCAD deficiency, this would be, for example, anywhere between a couple months and a couple years, and I'll tell you why that is in a moment. And what you see in these babies is, unfortunately, they go from looking pretty normal to developing non-ketotic hypoglycemia, which can lead to coma, seizures, and death. Now, hypoglycemia, that's actually relatively common in newborns. This, though, would be a profound hypoglycemia, and to be non-ketotic, meaning not making ketones, despite your glucose being low, would be very odd and would point you towards a disorder of fatty acid oxidation. So in addition to these very serious consequences, you also will see some things that are, relatively speaking, a bit milder, that result from toxic long-chain fatty acids building up in the liver, the muscle, and the heart. Long-chain fatty acids build up because an enzyme downstream of them in fatty acid oxidation is deficient. And these can cause fatty liver and hyperammonemia. They can cause lipid storage myopathy, and then finally cardiomyopathy, as the long-chain fatty acids build up in these tissues, respectively. Now, not all individuals present in infancy. You can have late onset presentations, or you can also have individuals that, having survived through this infantile period, can develop additional symptoms as they go later on in life. This might be cardiomyopathy and weakness and rhabdomyolysis. Now, I think I've alluded to this a little bit, but when you see these disorders present or become exacerbated is in times of fasting, during illness, or during some stressful event like a surgery. The reason this is that, keep in mind, the whole pathway is getting energy out of fatty acids and then, importantly, ketones as well. And ketones are this model product that you make when you don't have sufficient energy from other sources. So take, for example, fasting, you need a whole lot of energy. Take, for example, illness, you're also hypermetabolic. Same thing with surgery or other crises. You need to make those ketones. You need energy from fatty acids, but you're not able to make them. So energy from other sources is wholly insufficient, and you result in this metabolic crisis. Now, if you have no crises, you can have a good prognosis. And going back to MCAD deficiency, for example, actually, if you avoid the crises and any sequelae that you would have from a metabolic crisis, you can have a kid that is totally normally developmentally, and you can have an adult with a totally normal lifespan, which is wonderful. Now, in terms of the presentation of MCAD, I mentioned from a couple months to a couple years. Why is that? Well, if you think about it, in terms of these things, infants, when they hit a couple months of life, start sleeping through the night better, and therefore having longer periods where they're not eating anything. They start to get sick more as they get to a couple months or a couple years of age. They start to go to school or daycare, meet other kids who are sick. And then things like surgery and stuff, obviously over time, you're at higher risk for these things as sort of, you go along in years. One other specific disorder to mention in addition to MCAD deficiency would be LCH-ADD. MCAD deficiency, just to spell out, is medium chain acyl-CoA decarboxylase deficiency. A lot of these have very long names. If you want to learn more about the enzymes, go back to part 1. This one's even longer, and in this case it's long chain 3-hydroxyacyl-CoA dehydrogenase deficiency. I mention this specifically because whereas all the disorders tend to be kind of generic in the way that they present, they're all very similar, this is a special feature. And in this case, if a fetus is affected with this condition, the mom during pregnancy can actually have fatty liver pregnancy or the HELLP syndrome. And this is hemolysis, elevated liver enzymes, and low platelets. And I just mentioned this not in that it's super common, but it's just this cool case in which a phenotype can be present in a mom based on the genotype of the infant, of the fetus who's developing inside her, albeit in the context of her being an obligate heterozygote carrier for the disorder. So on to the molecular features. These disorders are, of course, caused by deficiency or defects in enzymes of the carnitine shuttle and of fatty acid oxidation proper. It results in decreased acetyl-CoA being made from fatty acids and also in decreased ketones, and I mentioned these things previously. Some other features is that you tend to get actually buildup of acyl-CoAs, and we can look back at the pathway to see why that is. Acyl-CoAs are present here and here, so if you have downstream defects, those can build up. These can then get metabolized by enzymes, and these would be acyl-carnitine transferases, that can then produce acyl-carnitines from these acyl-CoAs that have the same length of acyl chain in each of these species. And what you tend to get is based on where the defect would be. So for example, is it in the long chain enzymes, the medium chain enzymes, or the short chain enzymes? You actually get this characteristic pattern of the acyl-CoAs that build up and therefore the acyl-carnitines that build up. And a key test, and arguably the key test in diagnosing these illnesses and saying specifically which fatty acid oxidation disorder it is the acyl-carnitine profile that we'll talk about more here and in lecture 3. And so I bring this up just to say that there's this specific metabolic signature of each of these disorders that's most keenly ascertained by looking at the acyl-carnitines. Using MCAD as a specific example, this is a medium chain enzyme deficiency. And so we end up with C10, C8, C6 species. These would be either acyl-CoAs or acyl-carnitines that have 6, 8, or 10 carbon chains hanging off of them. This is the 8-carbon variety drawn out here of an acyl-CoA. And then for the acyl-carnitine species, I've just abbreviated it C8. We'll see a lot of these abbreviations when we look at the diagnosis part, specifically in lecture 3 as well. And in this case, the C8 acyl-carnitine is sort of the molecular signature of MCAD deficiency. One more thing I want to mention in this molecular section is that if you do have a buildup of these acyl-carnitines, you can actually sort of overwhelm your kidney's ability to resorb them via carnitine transporter. You spill those out and you can become carnitine deficient. Carnitine deficiency is another molecular signature of many of these disorders. So let's go on to the inheritance and prevalence. These are all autosomal recessive, but you do have some symptomatic heterozygotes some of the time. And in terms of the frequency, so if you look at all acyl-carnitine profile abnormalities, you would see something like 1 in 5,000 to 1 in 10,000 births has that. Given that the organic acidurias, for example, can also have acyl-carnitine profile abnormalities, then the total number of fatty acid oxidation disorder patients would be somewhere less than this. For MCAD deficiency specifically, for example, in northern Germany, you have a frequency of 1 in 4,900, so very high, on account of a northern European specific mutation, and then a secondary one that's a little bit less common, but also in the carrier state is quite common. Now contrast that with somewhere like in Taiwan, where it's even less frequent than 1 in 200,000. So it really does vary a lot around the world for MCAD deficiency. In the United States, we've got a mixed population, so it's somewhere in between, or an incidence of somewhere around 1 in 15,000. So let's jump on to how you make the diagnosis. As I mentioned, clinically, these disorders look a lot alike, and they actually look a lot alike some other types of disorders as well. So in the end, the diagnosis tends to be a laboratory one. This can be done in one of two ways. Ideally, that newborn screen, that newborn heel stick test is what's going to uncover this disorder so that within a couple days after birth, you know the individual has the disorder and you prevent becoming hypoglycemic and getting that coma, seizures, and death sort of syndrome before it even happens. Unfortunately, some of the times the infant will present too early, so the newborn screen result's not back, or if this is in a part of the world where the newborn screen is not done, you'll get a super sick infant. You'll check the glucose, of course, and it'll be low. Then you'll check ketones, they will be low as well, and you'll think about a fatty acid oxidation disorder. Once that's happened, you'll get a slew of other lab tests. As I mentioned, I'll go into these specifically in part 3, but I'll mention what they are for now. This is the acylcarnitine profile. We talked a bit about that. Free fatty acids you'd expect to be high. This would be during a time of starvation. You'd want to be mobilizing fats. You get free and total carnitine. I mentioned that a carnitine deficiency is one possibility. You get urine acylglycines. These are just acyl groups attached to another molecule that you urinate out rather than looking for them in the bloodstream. You get urine organic acids, plasma amino acids, and you get other tests as well. For treatment and management, a key thing is diet. If fasting brings these on, you want to avoid it. One way you can do that is to avoid prolonged exercise, do frequent meals. You also would want to prevent excessive exposure to cold, given that shivering causes increased metabolic demand. And in some individuals, you can give them nighttime uncooked cornstarch. That's this sort of low, slow, steady throughout the night source of glucose for them. So you're in effect avoiding fasting, even though the kids would not be eating. The meals should be frequent, high carb, low fat. If you just give generic fats, you're going to give some of those sort of upstream long chain fatty acids and things that can't be metabolized. You can go at it more specifically by avoiding specific types of fats and giving specific other ones. For example, in proven long chain fatty acid disorders, you just bypass the enzyme defect by giving medium chain triglycerides. Now, during illness, you want to give what I call TLC, which stands for tender loving care. Basically, these are the patients where they start vomiting, they've got gastroenteritis as a 1-year-old, for example. They come into the hospital before they get sick so they don't crash at home. And you would give IV glucose just to keep the glucose up, despite their inability to mobilize fatty acids and energy and into ketones. You can give carnitine if it's deficient as part of their syndrome, but not in the case of a long chain fatty acid oxidation disorder, as long chain acylcarnitines can actually be cardiotoxic. Now, if you have a carnitine deficiency, either a secondary one from spilling too many acylcarnitines or a primary carnitine primary carnitine deficiency, which is a deficit in this carnitine transporter here, you can actually give carnitine. You may wonder why carnitine would be deficient if you can't mobilize it into cells, like wouldn't it be high in the bloodstream? And it turns out this carnitine transporter is present in kidneys as well. So not only can you not bring carnitine into the cell, but you also can't resorb it from the urine. So you spill a lot of it out and you become carnitine deficient. Those would be cases in which you would supplement carnitine. Final thing I'll mention in the treatment and management is that you want to screen and counsel family members who are either at risk for the disease or at risk of being carriers and therefore passing it on again to another family member. Next, differential diagnosis. So a metabolic crisis like this, a generic name for that, and it tended to be used more in the old days when the specific biochemical defects like fatty acid oxidation disorders weren't even known yet. We use the term Rye syndrome or Rye-like syndrome if you know what's causing it. So for the differential, you think of all the other causes of Rye-like syndromes, which are all metabolic issues. The organic acidureas, urea cycle defects, disorders of ketogenesis, respiratory chain defects, and carbohydrate metabolism defects. Those can all cause clinically similar symptoms. Via the laboratory tests, you're going to differentiate between them. Also, when you're first seeing the patient, you got to think of things like, for example, hyperinsulinemia, where you'd get hypoglycemia, albeit a ketotic hypoglycemia. So very soon via your lab test, you'd rule those things out as well. All right, so for references, look in the info that I put below the video. I've got about a half dozen ones there that are awesome if you just want to review these disorders overall, or if you're interested in a very specific one because you're seeing a patient with that disorder either in clinic or in the hospital. Thank you so much for your attention. I encourage you to watch part 3 as well if you feel that it would be valuable to you. As always, I appreciate your feedback either in the comments below or at the email address quickmedicalgenetics@gmail.com. And I'm also looking for interested medical genetics trainees and professionals to start submitting videos to really make this a crowdsourced venture. Thanks again for your attention.